Okay, so I'm going to talk to you a little bit about COVID in the GI tract. We've sort of had a couple of years now to sort of figure this out, and I'll kind of summarize some of the data, much of which came from early in the pandemic. So we'll discuss mechanisms of transmission, some of the GI and liver manifestations, some specific GI disease side effects, and then we'll talk about side effects from medical therapies, some areas of uncertainty, primarily dealing with the role of PPIs and anti-secretory therapy, and I'll briefly discuss endoscopy and some conclusions. So one thing that we've been noticing over the past 20 years that these novel viral diseases are increasingly common, starting with SARS coronavirus in 2002, 2003, the H1N1 bird flu in 2009, MERS, a Middle East respiratory syndrome coronavirus in 2012, and of course the current SARS coronavirus 2 for the disease COVID-19 from 2019. What's different, obviously, about SARS-CoV-2 is that it's highly transmissible during the preclinical phase before patients, perhaps can get a chance to isolate themselves because of symptoms, and that's really what's made this far more spreadable than the others on that list. So we know this is a beta coronavirus. It's a spherical positive single-stranded RNA virus. And these coronaviruses have been now known for about 60 years, and they typically cause enteric, neurologic, hepatic, and respiratory symptoms. And I'll be focusing obviously on the enteric and hepatic symptoms. Species that are affected outside of humans are cattle, cats, camels, and bats. And of course, bats are the proposed sort of origin of this virus. 7 coronaviruses currently known to affect humans, and they share the current SARS-CoV-2 is 79% similar to the original SARS virus from 2002-2003, and about 50% similar to MERS. And again, it's very similar to the bat coronavirus, which is why it's believed to arise from that. So this is sort of the cycle. Sort of bats sort of then infect another species, usually an intermediate host, which in this case is believed to be, believe it or not, the anteater, which then subsequently then can infect human hosts through the ACE2 receptor. And then, of course, once that enters either into the GI tract or lungs, it can spread typically through respiratory droplets and aerosols from human to human. So again, here's the sort of 3 recent coronavirus agents over the past 20 years. Again, you see the origin is bats. They have different intermediate hosts, and their incubation periods typically range from between 2 to 3 days up to 14 days. So again, the mechanism of GI involvement is the ACE2 receptor, which is the target of entry for this virus. And these are expressed in the stomach as well as in the duodenum and the rectum. And this may provide a potential vehicle for fecal oral transmission. And it's also actually it's been found in hepatic cholangiocytes and hepatic cells. So there are these receptors elsewhere as well. So that's a little bit about the virus and how it transmits. We'll talk a little bit about GI manifestations. So the most common symptoms are diarrhea, nausea, vomiting, and anorexia. Abdominal discomfort is less often. Of course, there is loss of smell and taste and some bloody diarrhea. And from a hepatic perspective, it's usually levels of transaminitis, elevation in bilirubin, prolongation of PT time, or elevated LDH. So here's some initials. These are some early data, almost all from China. And this is relatively small, but you can see anorexia here that occurs in anywhere between 50 to potentially even up to 80% of patients in some of these studies. Diarrhea and nausea are reported somewhere between 30 and 50%. And then you see a drop when it comes to vomiting and abdominal pain. And GI bleeding actually is generally quite rare. So this is actually a large study that was spearheaded by Joel Munzer at the Medical University of South Carolina. And I'll note that both UCLA and Columbia contributed data to this. I know Dr. Sethi is an author on this, as is Dr. Condon and Leinhardt from our institution. we have 36 centers from North America. It's all from Canada, the US, almost 2,000 patients. And these are all hospitalized patients. And they wanted all of the first 50 to at least the first 50 and preferably 100. 53% of the patients had at least one GI symptom on presentation, and about 3/4 of those symptoms were mild. And what the study basically found was that GI symptoms or elevations in LFTs on admission did not predict independently with the need for mechanical ventilation or death. Again, this is the table that sort of describes the study population. You can see a fairly broad range of ages there, about just about 57% male, and you can see probably an overrepresentation of African Americans, around 40% compared to the general population. Here's a sort of a map here that just kind of shows all the different centers. Actually, Columbia, Dr. Sethi's institutions on the far left there, they had fewer GI symptoms, and Johns Hopkins had the highest rate of symptoms, almost 80%, and UCLA is just a little bit under that mean of around 70% in terms of symptoms. Now, this sort of summarizes that in more aggregate form. So you can see that there is approximately about somewhere in the range of, just a little over half of patients had some symptoms, but the majority of those, 3/4 of those are mild, and only about 1/4 of those ended up being moderate or severe. And again, you can see that diarrhea is by far the most common symptom that's present there, followed by nausea, and then vomiting, then abdominal pain, and then really the rest of symptoms are rather rare. So if you take this in aggregate, so I kind of presented you to the largest US study, what about if we pool data from around the world? So this is 2,477 patients from 17 studies. So you can show you just the size of that North American study, which in itself had nearly 2,000 patients. So this obviously doesn't include that. But there was no difference in diarrhea or nausea, vomiting regarding disease severity. But what they did notice was that if you had severe COVID disease, you were 7 times as likely to have abdominal pain. So instead of GI symptoms predicting severity, the severity may actually predict the GI symptoms. So in this study, again, these are all the individual studies, and the different colors represent the different symptoms. So you have yellow is diarrhea, blue is nausea, vomiting, green is abdominal pain, and red is anorexia. And you can see anorexia was the most common in this, 27%, again, which is probably because the Chinese studies tended to have higher rates of this. And then you see that diarrhea is present in around 4%, and you have nausea and vomiting in around 6%, and abdominal pain really in about 1 in 40 patients. So the AGA also conducted a meta-analysis looking at 47 studies that looked at nearly 11,000 patients. Again, almost all of these patients are inpatients. So really, we don't have a lot of outpatient sort of symptom data. But again, this was 56 different studies, 47 studies that had unique patients. And again, as you can see, because most of these studies originated in the first 6 to 8 months of the pandemic, the majority of the data, at least in terms of study numbers, were from China. And again, nearly all in adults. Again, 55 of these studies were really on hospitalized patients, or a combination of inpatient and outpatient. Only 2 were exclusively on outpatients. And again, they nearly all reported GI symptoms. About half reported liver abnormalities. About 1/3 provided background data on whether they had GI symptoms or underlying conditions to begin with. And when you look at this now, this is probably the largest group. You see that diarrhea is present in about 8%, as is nausea, vomiting, abdominal pain around 3%. And you can see that stool shedding is quite common, seen in about half the patients. And interestingly, even in patients that had respiratory specimen after infection that had turned negative, that about 2/3 of those patients still had stool samples that were positive. So one of the questions was, is there some difference perhaps from what the Chinese were seeing compared to everywhere else in the world? So they actually sort of broke the results up to sort of aggregate to Chinese studies only to non-Chinese studies. And what they found out is that diarrhea, nausea, vomiting, and liver abnormalities were more common outside of China than in. And this is the data showing that the overall diarrhea rate was 7%. It was about 6% in China, 18% elsewhere. And again, you can see that there's a roughly 10-point increase in nausea, about a doubling of abdominal pain from within China versus out, and about a 5% increase in AST, ALT in the non-Chinese studies compared to Chinese. So moving to liver manifestations here, again, this goes back to the US Canadian study of nearly 2,000 patients. One of the issues that have been is an issue with a lot of the other studies is that they don't really define what level. There's variable definitions of what constitutes abnormal LFT. So in this study, it was defined as anything within 1.5 times the upper limit of normal was considered normal. They only looked at ALT and total bilirubin. They saw mild elevation was defined as 1.5 to 3 times the upper limit of normal. Moderate was from 3 to 5, severe more than 5. And basically the upper limits for normal were defined as 45 and 1.2 for ALT and bilirubin. So if you take a look at this, on the left is sort of how often you saw abnormal liver tests at admission, and on the right is how often did it occur at any time during hospitalization. So you can imagine it's going to be higher on the right, and it is, but you can see that the general trend here is that these these are present in approximately somewhere in the range of 20 to 25% of any liver test abnormality at admission, but it's only in around 15% if you include the ALT or the bilirubin as I defined here. And most of those elevations, as you can see, the middle and the right 2 columns are sort of mild, moderate, and severe. So you can see almost all of the LFT elevations were in that 1.5 to 3 range, and less so in the higher ranges. And so you can see that the numbers increase, but the trends stay generally the same across the way. Now, if you just say, what about the pool data from all the different studies? This is that 10,000 patient sort of meta-analysis. You see AST or ALT elevation at around 15%. Again, these are mostly hospitalized patients. And again, as I mentioned earlier, they don't always tell you what defines, it's not as clearly defined as that North American cohort that I just mentioned. So we'll talk a little bit about disease-specific side effects. So this basically then sort of looked at in the North American cohort. If you take out the people compared to who have GI problems versus don't, is there any significant difference in terms of the numbers? And the short answer is not really. Basically, it's whether you include all people or people who did not have GI symptoms at baseline. The overall numbers in terms of these main symptoms of diarrhea, nausea, vomiting, and abdominal pain, those are the big 4, remain relatively the same. And it's exactly the same thing if you take a look at liver, liver abnormalities, very much similar in terms of the severity of whether they have elevations and if they were mild, moderate, or severe. So no real change if you had underlying liver disease or not in terms of the severity or frequency. In small numbers of patients, however, had underlying chronic liver disease in the majority of these studies. There's an Italian study of ICU patients that found only 3% of those had chronic liver disease. The Chinese study only found 2% had chronic Hep B, which is somewhat surprising given that population. And early international data have suggested some increased death rate with chronic liver disease, but really most of those studies were relatively small. What about COVID-19 and IBD? I think it was discussed about the role of vaccination and the importance of vaccinating those patients. Again, it's not clear what the role of disease severity at baseline IBD plays in the severity of the subsequent COVID infection if it was acquired. It's unknown if active IBD increases your chance of getting COVID-19. It's generally recommended that A5-ASA be continued, even in a patient who's develops COVID-19, and it seems that the budesonide as well. Patients should certainly be on that. If they develop it, they may well be able to stay on, and it's really only suggested the stronger immunosuppressants may perhaps be discontinued in the short term during disease and then resumed once patients have resolution of COVID-19 symptoms and 2 negative nasopharyngeal PCR tests. So pancreatitis, these are several case reports of pancreatitis, and so it's definitely something we've seen. I think a lot of us have had exposure to that. This is a table just sort of looking at sort of patients with pancreatitis and COVID and if we could find another cause. And the short answer is that it's in many times there isn't another cause, but sometimes there is, and there's no clear correlation if this is really causal or just simply correlated with severe illness. In terms of side effects from medical therapies, again, this is sort of some of the drugs that are typically used, and I'm not going to, in the interest of time, go through that. But these are, again, looking at things like remdesivir and hydroxychloroquine and other medications that were used, especially in the first 6 months in terms of treating. And they looked at sort of what are the frequency of side effects in terms of the GI side effects potential, and essentially there's a slight difference in the total numbers, but you can see the relative ratios are nearly identical. It's just a small percentage difference, which may be related to medication, but the overall magnitude of these results is very small. And similarly, you can see that the results here for hepatotoxicity, any range in kind of in the 35% range. If you specifically look at ALT or bilirubin, it's kind of runs in that 19-20% range, and most of these are mild. So one thing that got a lot of debate was the role of PPIs, and do PPIs potentially make you get COVID infection or get you more severe disease? And so this was originally arising from a paper that looked on from a survey, and they did 250, over 250,000 invites. They got 86,000 completed surveys, and 53,000 of those patients had GI symptoms. And they asked those patients, well, do you take a PPI or an H2 blocker? And out of that group of symptoms, they had 3,386 or 6% who got COVID. And what they found was those who said that they took a PPI, the odds ratio for getting COVID seemed to be higher, 2.15. And if they took it twice a day, it seemed to be even higher at 3.67. They noticed that H2 blockers weren't associated with it. Now, this is from that same data set I mentioned from North America, and this study actually found somewhat the opposite. That this is more based on severity, but not really the risk of infection. But they found that PPIs were not associated with you getting worse risk of ventilation or death. And interestingly, that H2 blockers did seem to be associated with a modest increase in the risk of ventilation or death. So this again focused on a slightly different question, which is if you have it, will your disease be worse? And it doesn't appear to be the case, at least in North America, for PPIs. This is a recently published study in Gut from Korea that looked at 132,000 patients in the first 4.5 months of the pandemic. And what they found out was that the test positivity rate among those with current or past use of PPIs versus no PPI was not, there's no difference between no use. So it doesn't seem, PPIs did not seem to increase your risk of getting COVID, but among patients with confirmed COVID-19, current use of PPI conferred an 80% greater risk of severe clinical outcomes. So again, the data is very mixed because I just showed you the North American data suggests that it's not associated with it, but the Asian data suggests that it does. So the short answer is that we have several large studies that have looked at this, but we don't have clear data suggesting a role of PPIs. So in closing, I'll talk a little bit about the findings on endoscopy. Again, in general, it does not appear that there's a significant sort of COVID-specific findings on endoscopy. Many of these patients are sick, on steroids, on ventilators in an ICU. And so most oftenly they're there for a GI bleeding or enteral access, and usually we see erosive or inflammatory change. Again, specific changes to COVID are unlikely. One thing that we've had several studies now look at in the past 2 years is clearly showing that endoscopy, as one would have probably expected, is an aerosol generating procedure. And this increases greatly with coughing and belching, and that this generates droplets and aerosols that can translate quite a distance across a room. And so therefore, clearly it's important in these patients to take appropriate respiratory protocols. Colonoscopy is a little bit more controversial. It's possible through insertion and removal of instruments through the biopsy channel in that area, perhaps through flatulence as well. And there's been a variety of sort of things to mitigate the sort of aerosol generating potential from upper endoscopy, including masks with a hole and a slit, covering up the face, as you see on the bottom left, or even creating these clear plastic shields, which have been shown to be effective in reducing the potential for droplets across the room. There's several sort of guidelines on practice operations, but obviously with the nature of this pandemic and the mutations in the virus and variants, this often changes. But however, there's no evidence that standard reprocessing and cleaning steps are not effective in inactivating the SARS virus. So in conclusion, SARS-CoV-2 is a coronavirus that primarily targets ACE2 receptors in the lungs, but it can involve the GI tract. GI symptoms and LFT abnormalities are relatively uncommon. They typically occur probably 15–20% of the time for these things, but they don't really appear to correlate with disease or predict disease severity. The role of PPIs remains still a mystery with directly contradictory results from some large studies. Again, COVID-19 is inactivated by standard endoscopy and cleaning protocols. And again, endoscopy safety during this protocols, during this pandemic primarily involves protection from droplets and aerosols, primarily during upper GI procedures rather than issues of device reprocessing. Thank you.